Good afternoon, everyone. I'm Dr. Tulika Ghosha, the Orations Coordinator. Welcome to the Dr. Prayagraj Mondal Memorial Oration. I would like to first call the President of the Ophthalmological Society of West Bengal, Dr. Ratish Chandra Pal, to please come forward to the dais. I'm requesting him to preside over this prestigious memorial oration session. And I would like to hand over the session to our moderator, the very efficient Dr. Manish Singh. Over to you, Manish.
Thank you, Tulikadi. Respected President, sir. I'll request the chairperson, Dr. Manoj Hajra, sir, the co-chairperson, Dr. Shekharnath Sarkar, sir, and the orator for today, Dr. S.S. Pandav, sir, to please come to the dais. I'll request our chairperson, Dr. Hajra, to please speak a few words about Dr. P.R. Mondal, sir.
First of all, I am giving thanks to OSWB to be the chairperson in this prestigious Dr. P.R. Mondal Oration. And I am giving thanks to Dr. Pandya. He has come from a long distance. We are anxiously waiting for his speech. I don't want to spend more time. Thank you, sir.
Thank you, sir. We'll request our President, Dr. R.C. Pal, sir, to please present a bouquet to our orator, Dr. Pandav. It is a matter of great honor for all of us to have Professor Pandav coming for this oration. As we all know, sir is the head and professor at PGI Chandigarh. He has had multiple key posts. In fact, I was very fortunate to work under sir as a joint treasurer when sir was the president of Glaucoma Society of India from 2020 to 2022. Sir has been also the president of Chandigarh Ophthalmic Society, general secretary of North Zone Ophthalmic Society, a vast experience in ophthalmology. Sir has done his glaucoma research fellowship in 2005 and glaucoma clinical fellowship in 2006 at Perth. He has been a visiting professor at Center for Eye Research, Australia, Melbourne, and during that he has done a basic research in functioning of glaucoma drainage devices. He's also been the coordinator for the GONE project. I think all of us should have a look at it. It's a very nice project where you can know how to learn disc evaluation and especially useful for diagnosing glaucoma. He received multiple awards, including the gold medal for the best publication in IGO in 2019, gold medal 2019 by Bombay Academy of Ophthalmology, gold medal by Uttarakhand Ophthalmic Society. He has also been awarded the Himotkarsh Award in 2020, delivered the first Foundation Day oration at AIMS Bhopal, deeply involved in research, more than 150 publications and more than 300 talks in various conferences. Apart from teaching ophthalmology, sir has also started a glaucoma support group way back in 2008 for the glaucoma patients, and he was also chairman of the COVID vaccination committee at PGI Chandigarh. Thank you so much, sir, for coming here. I'll request our chairperson, Dr. Sarkar, to please present the Oration Award medal. I'll request Pandav sir to please deliver his oration.
Good afternoon, everybody. And before I start my oration, I'm very thankful to Ophthalmology Society of West Bengal for the invitation and this honor to deliver the most prestigious Dr. P.R. Mondal oration, memorial oration here. I'm particularly thankful to Dr. Ratish Paul, the president of the Ophthalmology Society of West Bengal, Dr. Manoj Hajra ji, Dr. Shekharnath Sarkar, Dr. Devashish, Dr. Tulika Ghosh, Dr. Manish, and I have some more friends in the audience. We have Dr. Prashant here, Dr. Harjeet Singh, Dr. Ashok, and many more I know, and many I met today only. Thank you, Ophthalmology Society of West Bengal, for this opportunity and this honor. Before I start my oration, I'd like to pay my respects to Dr. P.R. Mondal, who has been undoubtedly the most influential and most respected eye surgeon of this region. Dr. Mondal was born in Fatehpur near Asansol in West Bengal, and he had his initial childhood, initial upbringing and training in his native place. Later on, he came to Calcutta Medical College to do his MBBS. And while he was a student, he was quite health conscious at that time also, and was actually received several honors for his interest in bodybuilding and healthy lifestyles, perhaps. Then he, after his MBBS in 1953, he did his DOMS from the same place, and later he went to UK for his fellowship in surgery. But he returned, he didn't stay there, he came back to his native place, and there he joined the government services in West Bengal, Health Services 1962, and also he was the visiting surgeon to his alma mater, Das Medical College, Calcutta. And that's where he actually started serving his own community, which is so important. And throughout his career, he worked in many places in West Bengal. I think he covered most of even the distant places, the most unreachable places, I would say, the communities, which I think you can imagine those are the days when the ophthalmology was not what it is today, and the access to healthcare was extremely poor. Even today is not perfect, but it's much better, and you can imagine those days when it was so difficult. And he reached out to distant communities and all the places in West Bengal, and he was a source of information. His work was so extensive that he was kind of looked upon as a source of inspiration by his colleagues as well as by students, fellows, and who all helped him, and he helped build their careers. Dr. Mondal joined ophthalmology Ophthalmology Society of West Bengal in later, and he was an active member of the society throughout his life. He also served as secretary of the society in 1973, and also he became the president of this very prestigious body in 1992-93. And other than he has been helping his students and other student bodies during his time. Unfortunately, he left. He had health issues towards the end of his life, and he left this for his heavenly award on December 2009. But I think that was a life well lived and very fruitful life, and I'm sure wherever he is today, he must be very happy, because what he started, what he created is still there. His legacy continues in the form of his work, remembering his work, and the fact that we are remembering him today is a great honor to a great soul. Before I start my presentation, I also can't forget my mentors, and I've been very fortunate to have many of them actually. I started my career at PGI Chandigarh, and Dr. Dogra, I think most of you might be knowing, he was the one who introduced me to ophthalmology. I came to ophthalmology because of him, otherwise I had to choose between general surgery and ophthalmology, but I think Dr. Dogra had influence on me, and I came to ophthalmology. Later on, I worked with Dr. Amod Gupta, and he actually inspired me to do a lot of things, especially mostly the research work. And I also had the opportunity to work with Professor Aya Jain, and very long and dear, close association with Professor Jagat Ram. I think that association still continues. I think this person on the top right, perhaps you won't recognize, he is William Huxley Morgan. He is the inventor of the Zen implant. And I had opportunity to work with him for 2 years, so I did my glaucoma fellowship with him at Perth, and after that where my glaucoma actually took off. So I am very indebted to all these individuals. And not only that, in the audience we have Dr. Harjit Singh here today. Actually, he was my mentor as well. He was my senior resident when I joined ophthalmology, and you can imagine how close the senior and junior resident bond is, and I think that continues till there. So thank you, Dr. Harjit, for helping me at this time. Now I'll talk to understanding the Bleb drainage from glaucoma surgery. I have taken this topic a little bit, will be a little different in the sense that I wanted to give another side of what we see from the what we see in the clinics, and have a little more different point of view about how we look at these things. Now, glaucoma surgery, you know, has evolved a lot, and over the several years, I would say, last almost 100 years, I would say, I think there have been a lot of things have been happening. But more recently, I think we have now MIGs and we have trabs and tubes. I think these are the procedures which are kind of ruling the space. In spite of so many advances, we still have externally draining procedures which are still the most effective when it comes to lowering intraocular pressure. When you really want lower IOP, say in low teens, I think you go back to trabs and tubes, and there's no better choice than that. So we want to look at a little closer look at these things. So what happens is that trabs and tubes, they are actually characterized by a bleb formation. So whenever we do it, filtering surgery or visualizing surgery, you get a bleb there, and it's through that bleb that the IOP is drained out, and that's how the IOP reduction happens. Now, glaucoma surgery is peculiar because on the one hand, we want a normal healing to maintain the anatomical integrity of the bleb, and also we want so that there's no bleb leaks, but also we want that a little bit of incompleteness in the healing, so that the fistula that we have created, that continues to function. Otherwise, there won't be no IOP reduction. Now, many of the time we get blebs which are good, like ideally low-lying diffuse and mildly normal vascularity, I would say, and that can be seen after the normal glaucoma surgery, or even after the tubes or trabs, both is the ADI or AGV that we use. But we want to see this kind of bleb. But unfortunately, that's not the scenario always. And good 30 to 40% of blebs, they become one of these kind of blebs, which are not good. Sometimes they are outrightly dysmorphic, and they don't function very well. And this is the problem we all face. So we have been looking at PGI, we have been actually looking at these blebs more carefully and trying to understand why these blebs, they evolve so differently in different individuals, and what are really the underlying problems there. So we go back to the basics, and if you look at the glaucoma surgery, so essentially what we are doing is we are inducing a tissue injury by way of surgery. So we are cutting the tissue, so there's an injury. We are introducing a little bit of foreign body in the form of sutures in the trabeculectomy, or in the form of a device. If you are doing an AGV or ADI or some other device, there's a large foreign body there. And there's an aqueous humor which is flowing through the system. Now we know that the tissue injury, the conjunctiva actually heals very quickly. If you make a conjunctival incision or a laceration, even if you let it remain there for a few days, is going to heal. And if you introduce foreign body, that might increase the healing time a little bit, but eventually the conjunctiva heals very well. But that doesn't happen in trabeculectomy. In a trabeculectomy, the wounds actually never heals in a way, because it takes at least 6 to 8 weeks to get a reasonable healing, and after that also these blebs, they keep on evolving for several months and sometimes even several years. So the healing actually never stops, or the wound modulation never stops in trabeculectomy blebs. And then we suspect that maybe the aqueous might be doing something there. So what is the role of the aqueous humor in this combination? Like you have now 3 tissue injury, you have foreign body, and you have aqueous. So what is the interplay of these factors? That's what we want to study in the first place. So what we did was we created a rat model of glaucoma surgery, and we have published this model a couple of years back in IGO. And what we did was that we had an experimental group where we put a tube in the anterior chamber, and you have a bleb. So that's kind of more definitive glaucoma model that we can have. But we also had controlled groups where we created an injury to the conjunctiva, made an incision, and just let it go, let it heal spontaneously. And we also created another model where we did the incision and put a tube but not connecting the anterior chamber, so that acted like a foreign body. So we had aqueous, we had injury with foreign body, and we had injury, foreign body and aqueous, everything together. So these were the groups we had for this experiment, and we used Sprague, Dali rats for this. So in total, we had 92 rats and different groups, and we sacrificed them at different levels and took the tissue to study study biochemistry. What is happening is we looked at the 10 most commonly associated cytokines, commonly associated with the wound healing and inflammation. So I'll just show you the result of the two main ones. All of them had some changes, but I think the most striking was the TGI beta and this interferon gamma. Now, if you look at the lower one is the simple injury to the conjunctiva. This yellow one is the injury to the conjunctiva plus foreign body, and this is all these two plus you have the aqueous flowing through the system. Now you can see here, if you have just a simple conjunctival injury, there's hardly any expression of the TGI beta. Now this is because TGI beta actually comes very early, maybe within 12 hours, and it has gone back because it has done its job. And so might have missed a little peak there. But if you have a foreign body, then it persists for at least 2 days, and by second day actually come back to the baseline. But if you have an aqueous flowing the system, you can see it's very prolonged expression of TGI beta, which takes almost 7 days to come back to the baseline. Now, this is in the rat eye. Now, human timeline is actually much larger. Now, if you extrapolate it to the human, it would be like 6 weeks. So, and that is what we see clinically. At least 6 weeks is take for the wound to heal. And similarly, if you look at interferon gamma here, now what interferon gamma does, it helps to take you out of that healing process, proliferative phase, and it causes wound remodeling of the wound. So excessive fibrous tissue will be removed so that you get a more natural healing. And that expression in the blue line, you can see when the TGF gamma should be high, it is actually low, and this expression is increased much beyond, again, 7 to 40 days. So these two actually telling the same story, that aqueous humor is somehow not letting the normal physiology of wound healing progress. So is there any correlation with the structural and functional tests? So we saw at the biochemical level, so something is happening. So we had another setup where we used a rabbit model here. So we put a experimental implant. So we 3D printed a device and we put it in the rabbit eye and looked at the functional as well as the histology later on. So what we measured was the porosity of the capsule. Now, when you put an implant in the eye, there's a fibrous capsule which forms around it. Now, how porous that fibrous capsule is what is going to determine how effective it is in control of intraocular pressure. So we measured the porosity of the capsule. So what we did was that we had a wet implant. That means this implant was connected to the anterior chamber and the aqueous was flowing through it. And we also put another implant in other animals where we kept it dry. So we put the implant, but we did not connect it to the anterior chamber. And subsequently, using a special setup, we measured how much fluid you can push through these implants. So how much fluid actually can pass through the fibrous capsule per minute at 12 millimeters of mercury pressure. And as you can see here, if the plant is kept dry, the capsule is quite porous. But if the aqueous is flowing through it, within 1 week, the porosity drops to about by 25%, and at 4 weeks, porosity drops by 80%. Now, there's a very large reduction in the capacity of the capsule to conduct fluid, and that's probably what's happening in the glaucoma surgery as well. So we also looked at the histology in these eyes, and you can see that in the dry the implant, the capsule is thinner and is kind of loosely arranged collagen fibers, but in the implant where you have aqueous is flowing through, the capsule is thick and is very densely thick. So you're probably thinking there was a big deal because we know the aqueous does these things, and there's a concept of good aqueous and bad aqueous. So we tested it further and we asked ourselves a question, so what if the aqueous is not there, and we replace aqueous with the BSS. So BSS is more physiological and it doesn't have any of the cytokines that the aqueous might have or it has. So we we set up another experiment on rabbit eyes again, and 17 eyes basically, and we kept these implants dry for 4 weeks. And after 4 weeks, what we did was that we infused BSS through this for 45 minutes at 16 millimeters of mercury pressure, and we did it for 45 minutes. And then afterwards, we went back again after 3 days and measured the porosity of the capsule, and again after 6 days. Now, as you can see, same thing happened here also. At 20 days, the capsule is very porous, but after 28 days and even beyond that, the porosity has come down by 80%. So it's not just the aqueous which is doing it, is any fluid if you pass through this tissue will have the same impact. So that concept of good aqueous and bad aqueous is not really valid. And what is more was that if you look at the capsular thickness in these eyes, the capsule in eyes was almost similar thickness. So there was no change in the capsular thickness. So generally we believe that the glaucoma surgery or the implants fail because there's a thick fibrous capsule forms around it. But that, to my mind, is a secondary from the device has already failed before the capsule starts becoming thick. So what it means is that the fluid flow through the tissue that is a subconjunctival stage alters wound healing, and maybe the main trigger for implant failure as the subsequent fibrosis is probably secondary to the high intox pressure because implant has already failed. So based on we have this model of Bleb failure, so normally if you have a surgical trauma foreign body, it will heal very quickly, and you have an implant, the capsule which stabilizes in 4 to 6 weeks time in rabbit eyes. But if you let the fluid flow through it, this dynamics changes, and now you have the fluid hydrostatic stress, or there's some result called fluid stress comes in, and this reactivates these inflammatory mechanisms. It activates and it is known in experimental studies that if you apply stress to the fibroblasts, they respond to the stress and they start migrating and proliferating in the lines of the applied stress. So fibroblasts, they come into picture, they proliferate, some of them become myofibroblasts, and they contract later. And these myofibroblasts are very active metabolically, and they produce a number of growth factors, collagen and extracellular matrix components. And this actually reduces the porosity of this capsule, and IOP goes up. And once the IOP goes up, it is high IOP in the eye as well in the Bleb area. Actually, there's a vicious cycle starting now. So you have high IOP, you have more stress, and you have more of these growth factors coming in, and it becomes a vicious cycle. And eventually, you get a Bleb like this until it is completely obliterated. So this cycle only ends when the Bleb is completely obliterated. But this also gives you some opportunities to target how we can actually get or reduce this phenomena. So most important thing probably is to restrict the flu. So as of now, we don't know how much fluid conjunctiva or subconjunctival space can handle. So we are flooding the subconjunctival space with fluid when you do surgery, but we don't know the conjunctival space tissue cannot handle that much fluid, and that's why all this is happening. So we can also have anti-inflammatory. So we already use them in our practice. Then we also use anti-fibrosis in the form of mitomycin C, and I'll talk a little bit about that also later. And also we have been using anti-VEGF with kind of a limited success. And then important thing is to keep the IOP low. So now if you follow all these steps, then maybe you can get better Blebs after your filtering surgery. Now it's important, I think the most important point here comes out is the restriction of the fluid. But how much fluid subconjunctival space can handle? There's no, actually, we don't have a clear answer to this. We tried some experiment in this, but we didn't succeed in that. The reason was that experiments were a little too elaborate. We needed to implant a pump which could, in the rabbit eye, in the rabbit body actually subcutaneously, which could pump fluid periodically into the implanted device. But our animals became very uncomfortable, so we had to stop that experiment on ethical grounds after 2 or 3 experiments. So till we figure out what is the best way to do it, might be maybe we don't have answer. But this is also a potential space for research on GDDs, that you can have glaucoma drainage devices which would inherently manage the blood aqueous flow through them. So we have just looked at the blood physiology, and we have seen that aqueous has effects. Probably it has some cytokines, we know that, and they are there. But other than that, it also has a mechanical fluid stress, which is actually causing the problem. And the subconjunctival tissue responds by production of a number of cytokines, tendons, fibroblasts, newly, and they recruit inflammatory cells as well as fibroblasts, and then the whole chain starts. But what we have not talked about is the vasculature, which is again very important. So we haven't considered in this model, we have not considered the blood vessels or lymphatic vessels. So I'll spend a little bit time on that as well. Now we know when we are doing glaucoma surgery, this is typically what happens is that we make an incision and there's a bleeding there, and we do a good cautery. We always advocate that you do less cautery, but invariably we end up doing some cautery, and cauterization means you're actually destroying all the capillaries, blood vessels are there, and including the lymphatic vessels which are there. And on top of that, we use mitomycin C to reduce fibrosis. And mitomycin C, actually, what it does, it stops these blood vessels and capillaries from growing back. So this is kind of double damage we are doing when we are doing surgery. So what happens as a result is that the blebs become very hypoxic and sometimes outrightly ischemic. And the ischemic area in the bleb, actually, it never gains vascularity. Sometimes it remain ischemic. And then what happens is that there's a VEGF drive, there's TGF beta and other things coming, and there's an attempt for vascularization. So vascularization comes around, but it cannot actually come into that area because we have treated that area with mitomycin C. So that is again a problem, and as a result, you get a lot of angry looking vessels, and eventually these blebs get very localized, they remain avascular, over a period of time they degrade, they degenerate, and they start leaking. So this is the problem when you are destroying these blood vessels during glaucoma surgery. And because there are no channels, there are no drainage channels there, so where does the fluid go? So this fluid will collect there, and many times it forms small cysts or a tendon, or outright tendon cyst, which becomes thicker over a period of time and till the blood fails. So we know about the blood, the fibrobascularization that happens, but what we have usually not considered is the lymphatic channels. And lymphatic channels, if they are destroyed, they also have effect, because now the fluid is going to collect there, and they can also cause, the excess fluid can cause the impaired clearance of the cellular debris, so that will be toxic, which are toxic to the cells, and it will lead to cell injury. And also it impairs the tissue remodeling. So in effect, it also have the same effect of delayed wound healing in these eyes. And also from histological studies, if you see the excised tissue from the blebs doesn't show any lymphatics in that. So there is an absence of lymphatic vessels in non-functioning blebs. And also the lymphatics are reduced in density even in blebs which are functioning. But more importantly, in the clinically also we'll see that in a bleb which is non-functional, you have a bleb there, is connected to the anterior chamber, and you can see the dye is not going anywhere. So we have injected methylene blue here, it has been injected, and you can see it's not getting drained. So this is not a functioning bleb because the tissue is now, the fluid is trapped in the tissue there. However, if you look at these eyes, you can see there's fine network of channels which are identified as lymphatic channels which are there. So lymphatic channels are actually associated with a good functioning bleb. Now the question is, can we promote lymphatic drainage? So there's another way to improve your outcome of the glaucoma surgery. So we set up another set of experiments here. So we did again 25 rat eyes, and we used the same model that we have used earlier. Now what we did was that we did the surgery, and we also injected, or on a cellular, on a collagen implant, we we soaked it with the retinoic acid, EC23, that's a synthetic retinoic acid, and also VEGF-C. Now, retinoic acid is known to promote angiogenesis, and VEGF-C is also known to promote angiogenesis. Like you have VEGF-A. VEGF-A and B are for vascular growth, like they increase fibrovascular growth, but VEGF-C actually does more of a lymphatic growth. So we use VEGF-C here soaked on a sponge, and again we sacrificed these animals after 14 days and stained them to look for with CD31 and D240 to look for these lymphatic channels. And as we can see, this is the VEGF-C group, where you can see the count of lymphatic channels is highest in VEGF-C, but also high in retinoic acid as in these two groups as compared to the baseline. So that means it is possible to modulate clinically these lymphatic channels, and we can attempt to increase these channels to get better results. Then other issue is that can we prevent the mysomine C induced damage to lymphatic vessels? Now, when we are if you are using VEGF-C to enhance lymphatics, the other factor, the fibrovascular proliferation is still happening. So, idea is, can we use mitomycin C to prevent fibrous proliferation, fibroblast proliferation, and at the same time get VEGF-C. At the same time, we get the lymphatics there. So in this experiment, this was similar to previous one, but here we did not create any fistula, but we just created a tissue injury model. So we injured the subconjunctival space, and then after injury, we injected just BSS as a control, or injected mitomycin C 0.1%, 0.01 ml actually. And we also did the mitomycin plus retinoic acid, that's 100 nanomole of EC23, that's the synthetic retinoic acid. And again, the eyes were enucleated after 14 days and tissue harvested for the staining. And it was, I think the results for the top two are the controls, so they have similar kind of lymphatic counts. But if you look at the bottom C and D, the C is with the mitomycin C, where the lymphatic count has gone down remarkably. But in the D, that lymphatic count is actually more than even the control. So that means even after application of mitomycin C, which is toxic to the vessels as well as to the lymphatics, one can prevent the harmful effect of mitomycin C if you are using retinoic acid and perhaps VEGF-C as well. We haven't used VEGF-C in this experiment, but we expect similar result would be there too. So again, there's a hope of reversing the effect of mitomycin C on lymphatics. So failure of glaucoma surgery is due to abnormal healing, and understanding these processes can help us understand what is happening there better, and we can design better surgeries or better devices. And essentially what happens in glaucoma surgery is that the physiological response to tissue trauma and wound healing is exaggerated, and the inflammation is very dysregulated because of the continued stimulus of inflammation, and because of aqueous which is flowing constantly through the tissue. And also there is a dysregulated extracellular matrix remodeling, so which is not happening the way it should happen. And this all leads to Bleb failure. And we believe that excess of fluid in the tissue space is what is creating all these problems. And this is also known in other studies. Also we found that the fluid stress can cause a mechanical or any mechanical stress can actually sensitize or stimulate the fibroblast to produce a number of cytokines as well as growth factors, and via mechanotransduction signals, and they can lead to fibrosis and all the pathology that we have seen. So there are two important lessons here basically, or two important areas where one can go further to improve the outcome of the glaucoma surgery, and that is improve the fluid management in the tissue space. Now, that means we need to have some measure or some way or some device which can calibrated amounts of echoes into the subconjunctival space, and that can help for the better survival of these implants, and also to improve the tissue drainage from subconjunctival space, and that we can do by minimizing the trauma to lymphatics, blood vessels, and minimizing the inflammation, but also attempt to regrow blood vessels without fibrosis, because whenever the vessels grow, the fibrosis comes in. So we have to figure out a way to reduce fibrosis, but without damaging the vessels, and also regrow lymphatics. Thank you very much. This work has been done at over a long period of time at different places, and a lot of people have actually contributed to this, so I'm thankful to all of them. And most of this work has been done at the Advanced Eye Center, PGI Chandigarh. Thank you once again for this opportunity, and I thank you all the office bearers and all the audience to be here this afternoon and giving me this. This is a really a honor and honor for me to present this prestigious Dr. Mondal oration. And once again, thank you all. Thank you very much.
Thank you so much, sir. I'll request Dr. Hajra sir to please give the award plaque to Dr. Pandav. And we'll request our Honorary Secretary Dr. Debashish Das sir to please hand over the certificate. Thank you again, Pandav sir. Can we have a group photograph? Please.